Hi, and today's lecture is about a little bit of cancers that we are looking at. So, first of all, let's just get into the cancer that I need to speak about, which gives kind of an idea, which is relatively easier to grasp compared to cancer of the of the cervix. So, let's talk about endometrial cancer and hyperplasias. All right. Um, First of all, we need to understand the causes and its symptoms. So its symptoms is it's gonna cause atypical uterine bleed. All right. You also want to remember Palm Cohen. Palm Cohen is good enough for any kind of examination. So AUB, Palm Cohen, you want to remember. Second, you want to talk about its causes. Okay. So what is going to be the cause and um, why does it actually occur? So any case of estrogen increase, all right, any case of estrogen increase can cause that. So late menopause, early menarche, ovulatory dysfunctions as such can cause all of it. So I think it's quite understandable to uh, derive all the different causes that we have from increased estrogen. All right, so that is something I will not get into. What I definitely need to get into is how do you manage. Okay, so you see atypical uterine bleed. There are risk factors like PCOS, tamoxifen use. Yep, that's a risk factor that I think it's worth mentioning. Tamoxifen. All right. There is all of this history: PCOS, tamoxifen, and obesity, hypertension, diabetes, all of it. And it's less than 45, that means it's around perimenopausal peri. So you want to do a TVS. TVS has to be greater than a certain value, about 12 thickness. But if it's a post-meno, your TVS has to be greater than only 4 mm. Simple as that. Simple. Okay. Okay, so once your TVS is around 12 mm, you need to go for further diagnosis. Or if your TVS is greater than 4 mm, you need to go for a further diagnosis, which is actually just endometrial sampling. What is it? Endometrial sampling. Now, how do you do endometrium sampling? There are a few methods to do endometrium sampling. One is you could do aspiration. All right, aspiration like a Carmen cannula is used. Carmen is kind of used for aspiration. Also, what we've been actually doing also is we're also doing biopsies, like endometrial biopsies, and this is a little more difficult compared to aspiration is more practical. Carmen, and we can also use your Pipel aspirator. All right, and once then you do your endometrial sampling. Now your endometrial sampling might have the following: it might have endometrial hyperplasia with atypia, and it might have without atypia. All right, without atypia. Now if it's without atypia, you just want to give progesterone, or you want to give a Mirena. You want to do a Mirena if it's a perimeno. Okay, or if it's a postmeno, you just want to give progesterone. You need to make sure that your endometrial hyperplasia is kind of contained. All right, it's kind of contained. You want to contain your endometrial hyperplasia. After 6 months, you do a follow-up. Now if it yet bleeds, if your bleeding is increased, or it persists, all right, or your atypical cells are yet there, your atypical cells positive, so then you need to do one thing, that is you need to do a dilation and curettage, and then you need to do you need to resect the area where your bleeding is yet persisting. All right, so simple as that. Dilation and curettage, hysteroscopy. You need to probably, if your spot is present of hyperplasia, you can actually just get rid of it. All right, so you give progesterone could be in the form of megestrol or medroxyprogesterone. You've got different types of progesterone, right? You've got first, second, third, fourth, fifth gen also now. So you have to talk about them. We will speak about these as well whenever we get the time. But eventually, for now, you do a DNC, and then you do a hysteroscopy. All right, you do a hysteroscopy. Now if it's now after 6 months, what you see? If you see after 6 months, again you see atypia, right? If you see atypia, then again you need to manage as in the form of atypia. So we've been speaking about endometrial hyperplasia with atypia. So what do we do when it's an atypical features are kind of noticed? All right, what do we do is we do simple stuff. All right, we do simple stuff. Simple stuff is what we do: the same thing. We do is dilation and curettage. All right, we do a dilation and curettage. Why do we do a dilation and curettage? Because we want to see if there is any endometrial cancer. All right, dilation, curettage plus hysteroscopy, or you could also do a fractional curettage, right, plus hysteroscopy. hysteroscopy. Now, because this is so important, I really need you for you to understand that fractional curettage is more important. What is fractional curettage? Basically, if this is the uterus, the uterus are divided into different fractions, and you take a curettage from each sample. All right, it's better, much better. So do your fractional curettage. Now, if your fractional curettage and your hysteroscopy, all right, is probably positive, then you need to do your management. You need to manage. You manage by what? You do if it's a premenopausal, all right. If it's a premenopausal, probably you're looking at you could be doing total abdominal hysterectomy and simple hysterectomy if you want. If it's postmenopausal, it's better to remove even the ovaries, all right. So ovaries plus salpinx removed, all right, salpinx. So you do a transabdominal hysterectomy plus bilateral salpingo-oophorectomy, all right, plus BSO. Now that's simple as that, okay. It's as simple as that, and that is why I told you that it's really really easy. Endometrial hyperplasia, it's not that difficult, right? It's not that difficult. As I told you, drug of choice, if AUB is present with atopia and hysteroscopies, they do not want to get an hysteroscopy, or they want to, if family, if and only if family, or refusal, all right. Family is not complete. If family is not complete, there is a refusal. You want to give one progesterone. What progesterone? Medroxyprogesterone acetate, or medroxyprogesterone. Or you could also go for your Mirena. Or you could go for Megestrol. Now, Megestrol, right? Megestrol. Pardon the spellings. I am assuming that medroxyprogesterone is something that we know. I am assuming Mirena is something that we know, but I'll write it. It's an IUCD. Not IUCD, IUD. Progesterone IUD, all right. I'm not going to say IUCD because people think it's copper. However, that's not the copper. IUCD is different, but for the sake of it, this was a question that I actually got. Anyways, Mirena, MPG, and Megestrol. These are the drugs that you can give if your family is not complete.